Dear students, I trust your FMGE exam went well and you will be soon giving us the happy news. As a tradition, we are supposed to collect the questions which came in your exam. It will be a quick recall, and once I have the optimum options and the detailed discussion will be taken and uploaded on the YouTube and the application. So this is going to be a quick recall session as we do not have the proper questions and the options available with us. Kindly provide the contributions so that the discussion becomes fruitful. The very first question which I understand came to you is name the type of joint which is present at the arrow marked region, and what we find is the medial bone ulna is shown here, the lateral bone is the radius, it is the middle radio-ulnar joint here, which is slightly mobile joint. It is a fibrous joint helping us slightly for supination and pronation because most of the movement will be happening at the superior and inferior radio-ulnar joint. So it is a fibrous joint, and fibrous means desmos, so it is a syndesmosis joint. As you can see, we can mark our answer as choice number B. And if it comes to the superior and inferior radio-ulnar joint, then they are pivot synovial joint, which is also called as the trochoid synovial joint. They are freely mobile joint working for the rotation of the radius on the ulna, that is the pronation and supination. We can quickly go through the classification of joints as well. As you notice, if it is a joint between the skull bones, it is suture coming under the fibrous variety. Under fibrous variety, you have two more classifications. The tooth and socket, which is called as the gomphosis joint. And this was our question, middle radio-ulnar joint, the syndesmosis. So these are the three subclassifications under the fibrous joint. Whereas if you talk about the cartilaginous joint, there is a primary and secondary cartilaginous joint. Primary, which is called as synchondrosis, and secondary cartilaginous joint. Symphysis, slightly mobile joint. The epiphysio-diaphyseal joint in the growing children is the synchondrosis or primary cartilage joint. And once the hyaline cartilage disappears, there is a bony fusion. We will call it as synostosis. So adults will have synostosis. And symphysis, which is secondary cartilaginous joint, slightly mobile joint. The examples are pubis symphysis or midline intervertebral joints, slightly mobile joints. The next question we have got is name the dural venous sinus arrow marked in the radiograph. It appears to be a transverse section radiograph given to you, and if you are talking about dural venous sinuses, they are collecting the venous blood from the brain and meninges to pour it into the internal jugular vein. Now, if you are focusing upon this arrow mark, this is the region where a sinus is running anterior to posterior and is called as the straight sinus. It is formed by the union of great cerebral vein of Galen with the inferior sagittal sinus. Then it runs posteriorly as straight sinus to drain into confluence of sinuses on the posterior aspect. So presently we'll mark it as the straight sinus and have some more details. Here the choice number A is the answer, and we can look at one more diagram for the details. This is inferior to superior view. This is the patient lying in supine posture. The feet are towards us. Head is away from the viewer, and we are taking inferior view of the brain, and there you can understand the formation and the course of the straight sinus. The straight sinus is formed by the union of great cerebral vein of Galen, which is formed posterior to the brainstem, and this vein of Galen is receiving the inferior sagittal sinus. Together they'll form the straight sinus, which runs anterior to posterior direction and is joined by the superior sagittal sinus coming from superior aspect and occipital sinus coming from inferior aspect. Together they will form the confluence of sinuses, and from there will be two transverse sinuses taking the blood away towards the sigmoid sinuses, and which will then drain into the internal jugular vein. So the pointer was on the straight sinus, and that is what we have answered it there. The next question we have got is identify the arrow marked structure in the radiograph. It is a sagittal section, one radiograph where we are talking about some of the component of the brainstem. Choice D is the spinal cord. So here we'll find this is the telencephalon part of the brain showing the cerebral hemisphere. Then we have the diencephalon part of the brain, the thalamus, hypothalamus, etc. And then comes the midbrain. This is superior and inferior colliculus, the mesencephalon or midbrain, And then comes the pons. The arrow mark is on the pons. The pons and the cerebellum, pons being anterior, cerebellum posterior. Pontocerebellum is the metencephalon, and in myelencephalon it is the medulla oblongata, which will then be passing through the foramen magnum and continuing down as the spinal cord. Let us demarcate the spinal cord here, and if we are talking about the level of foramen magnum, there you do not have the spinal cord. It is the lower part of medulla oblongata passing. So we are demarcating the medulla oblongata here, and then you can mention the pons as well, where the arrow mark is. So this is the region of the pons, and above that will be the midbrain. We can demarcate the midbrain region here, superior inferior colliculus on the posterior aspect of the midbrain, and above that is the diencephalon part of the brain. There will be the thalamus, and below that is the hypothalamus. And if we are talking about the diencephalon, below that is the brainstem having three component: midbrain, pons, and the medulla oblongata. So our answer should be pons. As you can see, the choice number B becomes our answer here. In this question, there is one lesion in the hypoglossal nerve on one side, and they are asking for the position of tongue on protrusion. Let us say it is a lesion of the right hypoglossal nerve. It is a lower motor neuron lesion, and then you have to understand, normally there are two genioglossus muscles which will be working together to protrude the tongue, and they balance each other. Now, if there is right hypoglossal nerve injury, the right genioglossus is not working. So if the right genioglossus is not working, then the left genioglossus become more powerful, and it will push the tongue not only forward but towards the right side also, towards the side of the lesion. Will be better understood in the diagram. As we see, normally there are two genioglossus muscles which are working together to protrude the tongue. Actually, they aim the tongue, AIM. As you say, they move the tongue anterior, inferior, and medial. That is the protrusion of the tongue, taking the tongue downward and also towards the median line. But it is understood, if there is a right hypoglossal nerve injury, the right-sided genioglossus is not working, the left genioglossus become more powerful, and not only it will take the tongue anterior, inferior, and medial, it will keep pushing the tongue across the midline, and tongue will deviate to the same side of the lesion. So the opposed action of the normal genioglossus on the normal side with the normal hypoglossal nerve, the tongue deviates to the side of the lesion. As you see, this patient has right-sided hypoglossal nerve injury. The tongue is deviating to right side. There will be the tongue muscle atrophy, fasciculations can be there in the beginning, and that will take us to our answer, which is asking unilateral hypoglossal nerve injury. The tongue will be deviating to the same side. Choice number B should be our answer here. Right hypoglossal nerve lesion, tongue deviates to right side. This is a dissected specimen where they are asking us the arrow mark structure. And as we understand, this is the transverse section, the thorax region. The lungs are shown, sandwiching the mediastinum. The anterior bone is sternum, posterior bone is the vertebra. And between the two, we have some neurovascular bundle. They're asking for this arrow mark. And the names given are esophagus, SVC, IVC, or the descending aorta. Now, as I am magnifying this diagram, it is understood this is the posterior vertebra, and then we can also see just in front of the vertebra. This is the esophagus. So, lying in front of the vertebra, almost in the midline, is esophagus. Since the transverse sections are always viewed inferior to superior, it is understood that this will be the left side of the patient. This is the right side of the patient. So, what is running on the left side of the midline in relation to the esophagus in the thorax region? That is basically the aorta, descending thoracic aorta. So, as you mark the descending thoracic aorta, what about the ascending aorta then? And which vertebral level is this? You can see just in front of the esophagus, the trachea has already bifurcated. This is left principal bronchus, this is right principal principal bronchus. So this must be the T5 vertebra. So at the T5 vertebra level, you can show the two bronchi which have already bifurcated from the trachea. So this is the left principal bronchus, that is the right principal bronchus, and you can see even the pulmonary artery is dividing. This is the left pulmonary artery, this is the right pulmonary artery. You can show them as well. The pulmonary trunk dividing into the right pulmonary branch and the left pulmonary branch, and then you can see in close relation to the pulmonary artery is the aorta, the ascending aorta. So this is the ascending aorta and that is the descending aorta. Now you can demarcate the ascending aorta as well, as you are showing here. This is the ascending aorta. What is this vessel on the right side of the ascending aorta? And that is none other than the superior vena cava. This is a superior vena cava which will be receiving the azygous vein shown here. So let us demarcate both of them as well as we do so. This is the superior vena cava which is receiving the azygous vein. So as you look in front of the vertebra, on the right side is azygous vein, on the left side is arrow mark descending thoracic aorta, in the midline is the esophagus. You can see these details in a radiograph as well. We have taken one radiograph at the T5 vertebra level only, and let me zoom this area now. As we are doing so, the radiograph at T5 vertebra level, this was our marker, descending thoracic aorta. You can also mark the ascending aorta, then it will be on the anterior side. This is the ascending aorta. And then along with the ascending and descending aorta, you can also show in front of the T5 vertebra, that is the region of the esophagus. Just anteriorly to the vertebra lies the esophagus. And in front of the esophagus, we have tracheal bifurcation. As you see, this is the left principal bronchus, that is the right principal bronchus. And along with that, we can also see the superior vena cava. So this is the superior vena cava. And then you can demarcate the pulmonary trunk dividing into right and left pulmonary artery. The right ventricle sending the main pulmonary trunk dividing into left and the right pulmonary artery. Pulmonary artery relates with the ascending aorta, which is then related to the superior vena cava. And in our question, we already have marked it as the descending aorta. If you look back at the question, it was asking us for this arrow mark, and that arrow mark is none other than the descending aorta. So our answer should be choice number D here. And we can move on to the next question then. A patient has come to you in the emergency room and with pain and swelling in the right shoulder joint region, and you are suspecting there's a fracture in the clavicle. So what is the most common site of the fracture? Usually it is the junction of the middle 1/3 and the lateral 1/3 of clavicle, but that terminology is not used here. So what should be our answer? Let us first look at a diagram and then we can come back to choose the options. Since it is the right-sided clavicle, we are showing it here, and one radiograph is also shown, which is actually a fracture of the right-sided clavicle. Now, when we are talking about the clavicle, it is understood clavicle can be divided into three parts. And as we do so, we are calling it as the lateral 1/3, the middle 1/3, and the medial 1/3. As I zoom this area, you can understand we have divided the clavicle into three parts: the medial 1/3, middle 1/3, and lateral 1/3. And most of the fractures will be occurring at the junction of the middle 1/3 and lateral 1/3. This is the point where the fractures will be occurring. Now, if you do not have the statement in the way we are discussing, there is another way of talking about this fracture. It is the junction of medial 2/3 and lateral 1/3. And that was in your option. We'll choose that option as our answer. But looking at the fracture once again, you can demarcate the boundary of clavicle here. This is the medial end of the clavicle, and then you are seeing there has been a fracture. You can also show the lateral 1/3 of the clavicle here. So you can see the level of the the fracture, which we have mentioned, it is the junction of the middle 1/3 of clavicle and lateral 1/3 of clavicle. But if that option is not available, we can also say fracture commonly occurs at the junction of medial 2/3 of clavicle and lateral 1/3 of clavicle, and that will give answer to our question. So here, as we see, the choice number B should be fitting into the most appropriate answer. So we'll keep it there. But best is junction of the middle 1/3 and the lateral 1/3 of clavicle. That is the best possible answer if we could find in the given options. This is a case of frozen shoulder and the marked muscle has been involved. Now, which of the following movement have been compromised at the shoulder joint? As you see, we can find the scapula. So it is a posterior view. This is the right-sided scapula, and then the right humerus. This is the right shoulder joint. The muscle they are showing with the arrow mark is the supraspinatus muscle. It is lying above the spine of the scapula. The origin is supraspinous fossa scapula, and then you can see it is inserted on the greater tubercle of the bone humerus, contributing to the rotator cuff, the musculotendinous rotator cuff stabilizing the shoulder joint. So this is the supraspinatus muscle. And what is the function of supraspinatus muscle? Because that is the one which have been compromised in this patient. Supraspinatus is the initiator of the abduction. It will be helping the humerus to elevate, and 0 to 15 degree of abduction at the shoulder joint is chiefly done by the supraspinatus. If it is not working properly, then obviously our answer will be choice number A here. Shoulder abduction will be compromised in this particular patient. This is a diagram-based question where they are asking us to identify the arrow-marked tendon. And as is evident, this is the region of the anatomical snuff box bounded by some tendons, and the tendon which they have shown in the arrow mark is extending the thumb, extensor pollicis. It's a long tendon, so extensor pollicis longus. Coming from the posterior forearm, let us demarcate the course of this tendon here. It will come from the posterior forearm, and it is going to extend the thumb, hence the name is extensor pollicis longus. It is going to form the posteromedial boundary of the anatomical snuff box, and then anterolaterally there is another extensor tendon, that will be extensor pollicis brevis, again coming from the posterior forearm. So we can demarcate that tendon also coming from the posterior forearm, and here it comes. It is the extensor pollicis brevis. This is going to form the anterolateral boundary, whereas extensor pollicis longus is forming the posteromedial boundary. Now, we will find that in the anterolateral boundary, there is an additional tendon, which again comes from the posterior forearm. We call it as abductor pollicis longus. We are going to show that tendon as well now, the abductor pollicis longus. And it is seen that these two tendons, which are forming the anterolateral boundaries, can be compromised in dequervain tenosynovitis. And if there is a case of dequervain tenosynovitis, then one test will become positive, which is called as the Finkelstein test. So how do we do the Finkelstein test? We will see in another diagram. But here, as the arrow mark is asking, it is extensor pollicis longus tendon. And we can take our answer as choice number C here. And talking about the dequervain tenosynovitis, the anterolateral boundary getting affected, the Finkelstein test, will be seeing these two tendons if inflamed. There will be a painful maneuver, which is shown in the next diagram. Sudden ulnar deviation at the wrist joint will be producing pain in the anterolateral boundary of anatomical snuff box. One long and one short tendon getting involved, and the names are extensor pollicis brevis and abductor pollicis longus, forming the anterolateral boundary of anatomical snuff box. This is Finkelstein test. Normally, there won't be any pain. But if there is pain in this maneuver, that means it could be a case of dequervain tenosynovitis. Here a question has been put asking the marked line correspond to which vertebral level. And as we see, it is a transverse line put just above the umbilicus and at the lower end of the costal margin. So this appears to be the subcostal plane. And if it is the subcostal plane, then it is below the transpyloric plane, which itself is at L1 vertebra. So this must be the L3 vertebra level, because umbilicus lies at the intervertebral disc between L3 and L4 vertebra. As I am suggesting, this must be the subcostal plane, means under the ribs, and is lying at the vertebra level L3. Because if this is the L3 vertebra, there will be L4 vertebra here, and the disc between L3-4 vertebra, that is where the umbilicus is lying. Though the dermatome is T10 dermatome, skin supplied by T10 root value, but posteriorly the vertebral level is L3-4 vertebra. And if you are talking about the transpyloric plane, then it will be here at the tip of the 9th costal cartilage. Will have the transpyloric plane, where lies the pylorus of the stomach, and this is going to be the L1 vertebra, but the lower border. So we can have a look over another diagram also discussing the two planes. The transpyloric plane, where lies the pylorus of stomach becoming the duodenum here. This is the subcostal plane. There is one more plane which we can discuss in the next diagram, but at the moment, if you are talking about this line, it is L3 vertebra. So choice number D should be our answer here. And now we are looking at the diagram, explaining more details. So here we can see this is going to be the transpyloric plane, the adhesions plane, where you have the pylorus of stomach. L1 vertebra, the lower border. Let us demarcate it here. The transpyloric plane, adhesions plane, lower border of L1 vertebra. The line which was given to us is subcostal plane at the lower end of the costa, the ribs. So this is the costal margin. This is the subcostal plane, which you can demarcate now with a line here, passing through L3 vertebra, which we already have put as our answer. Then if we look at the umbilicus, it is at the intervertebral disc between the L3 vertebra and L4 vertebra. Disc lies posteriorly, umbilicus lies anteriorly. And one more plane which we want to see is the transtubercular plane. On the iliac crest, there is iliac tubercle, and through the tubercle, we are putting the transtubercular plane. So we have seen the three planes now, and transtubercular plane is at the level of L5 vertebra. Then comes a question which is asking which arterial pulse is being taken. The names are telling it is something to do with the tibia or the dorsum of the foot or an artery on the sole, the plantar aspect. In fact, if you see, the examiner is putting his hand on the foot, taking the foot into inversion, and the artery is lying behind the medial malleolus, behind the tibia bone. First it was running in the calf region, now it is coming behind the medial malleolus of the tibia bone. So this is none other than the posterior tibial artery pulse which you are taking. Let us have some more details regarding this artery, and we see this is the lower end of the tibia bone, where we have this medial malleolus, and lying behind the tibia bone, behind the medial malleolus, coming from the calf region, is the posterior tibial artery, behind the tibia, posterior tibial artery. We can take the pulse posterior to the medial malleolus and anterior to the triceps surae tendon or Achilles tendon inserted on the calcaneum bone here. So as you are marking the tendocalcaneus, the tendocalcaneus or Achilles tendon is coming and inserting on the calcaneum bone here, lying between the two, that is the tendo-Achilles, and the medial malleolus is the posterior tibial artery. It is passing under the flexor retinaculum and giving two branches in the sole, medial plantar artery, lateral plantar artery. So what passes under the flexor retinaculum is posterior tibial artery. If you are talking about the dorsalis pedis artery, it will be on the dorsum of the foot. And these arteries are to be palpated. We have to see the strength of the pulse if you are suspecting a case of peripheral vascular disease, that is the Berger disease. The pulses will become weak in that case. So dorsalis pedis artery, which is a continuation of anterior tibial artery in front of tibia. But in our question, we have to answer it as posterior tibial artery. And we can mark our answer now. Here is choice choice number B. So choice number B should be our answer. And as I mentioned, it is a quick recall because we do not have the proper question and proper option with us. Kindly provide your contribution so that we can have the proper question and then we can have a detailed discussion upon the same. And all the very best for your results. Give us the news of your success as soon as possible. God bless.